What if I told you that one of the biggest threats to your health after 60 isn't a disease you haven't screened for, it's actually a screening test your doctor may have already recommended? Most people walk into their physician's office after 60 believing that more testing always means more safety, more peace of mind and a longer life. That's a deeply human instinct. But here's what the medical literature has quietly been telling us for years, and what many doctors either don't have time to explain or frankly don't emphasize enough. Some of the most commonly recommended screenings for adults over 60 carry real risks, real costs, and in a surprising number of cases, they don't actually help you live longer or better. In fact, for certain individuals, they can set off a chain of events, unnecessary follow-up procedures, false positives, anxiety, complications, that does more harm than good. Today, we're going to talk about 5 specific medical screenings that fall into this category. This isn't anti-medicine. This is precision medicine. This is about making smarter, more informed decisions about your own body. Stay with me, because by the end of this video, you're going to understand something that most people, including many patients and even some physicians, never fully sit down to consider. Let's start by understanding why this conversation even needs to happen. The entire concept of medical screening is built on a beautiful idea: catch a disease early before it causes symptoms, before it spreads, before it becomes difficult to treat, and you save a life. And for many conditions that logic holds up. Screening for cervical cancer in younger women, for example, has been transformative. Newborn screening programs have saved countless children from metabolic disasters. The principle is sound, but here's where it gets complicated for people in their 60s, 70s and beyond. As we age, the mathematics of medical decision-making shifts. The potential benefits of finding something early have to be weighed very carefully against a whole set of risks that simply weren't as relevant when you were 40. Those risks include the psychological harm of a false positive result, being told you might have cancer, and then spending weeks in terror before learning it was nothing. They include the physical risks of the follow-up procedures that a positive screening triggers, like biopsies, surgeries, and imaging with contrast dye. They include overdiagnosis, which is the detection of an abnormality that would never have actually harmed you in your lifetime, but now becomes a problem because it's been found and labeled and treated. And they include the very real possibility that even if something is found and treated, it won't actually change how long or how well you live. These are not hypothetical concerns. They are well documented in peer-reviewed research. The United States Preventive Services Task Force, the American Geriatrics Society, and other major medical bodies have spent decades wrestling with exactly these questions, and their recommendations, which many patients never hear about, tell a nuanced story. Let's walk through the 5 screenings where that story is most important. The first is prostate-specific antigen screening, which most people know as the PSA test. For men over 60, this blood test is often done almost automatically as part of a routine checkup. The idea is to detect prostate cancer early. And that sounds like a no-brainer, doesn't it? But here's the thing, and this is something that genuinely surprises most men when they first hear it. The PSA test does not directly detect cancer. It measures a protein that can be elevated for many reasons: benign prostate enlargement, a urinary tract infection, even vigorous physical activity. When PSA comes back elevated, it typically leads to a biopsy. And prostate biopsies carry their own set of risks, including infection, bleeding, and significant anxiety. But here's the deeper issue. Prostate cancer is extraordinarily common in older men, and the overwhelming majority of those cancers are what researchers call clinically insignificant. Autopsies have shown that roughly 70 to 80% of men in their 70s and 80s have microscopic prostate cancer at the time of death, but they died of something else entirely, often something completely unrelated. When PSA screening finds these slow-growing cancers, the temptation is to treat them, and treatment, whether surgery, radiation, or hormone therapy, comes with a serious side effect profile, including urinary incontinence and sexual dysfunction. Multiple large, randomized controlled trials, including the famous PLCO trial in the United States, have found that PSA screening does not significantly reduce prostate cancer mortality in the general population. For men over 70 in particular, the current consensus from the USPSTF is that routine PSA screening is not recommended. The key takeaway here is not that all men over 60 should refuse the PSA test forever, but that this decision needs to be a real individualized conversation between you and your doctor, one that accounts for your personal risk factors, your family history, your overall health, and importantly, what you would actually want done if something were found. That conversation is not always happening the way it should, and that's the gap this video is trying to help close. The second screening in this category is cervical cancer screening, specifically the Pap smear and HPV testing for women over 65 who have had prior normal results. For decades, the Pap smear has been one of the most effective cancer screening tools in medicine for younger women. But here's where age changes the equation. By 65, a woman who has had regular, normal Pap smears throughout her adult life has already demonstrated that her body does not appear to be harboring a high-risk HPV infection that is progressing toward cancer. Cervical cancer takes many, many years to develop through a series of detectable precancerous stages. If those stages haven't appeared by 65 in someone who has been consistently screened, the statistical probability of it appearing afterward drops dramatically. Continuing to screen beyond 65 in these low-risk women creates more opportunity for false positives, which trigger colposcopies and biopsies, uncomfortable and sometimes anxiety-provoking procedures that carry their own minor risks. The USPSTF, the American Cancer Society, and the American College of Obstetricians and Gynecologists all agree women aged 65 and older who have had adequate prior screening and are not otherwise at high risk should stop cervical cancer screening. Now, there are important exceptions. Women who have a history of abnormal results, who were never adequately screened in earlier life, or who are immunocompromised may still benefit from continued screening. This is a personalized decision, but the blanket continuation of routine Pap smears in older, previously screened women is a case where the risk-benefit balance genuinely shifts, and stopping the test counterintuitively may be the smarter medical choice. The third screening is colonoscopy in adults over 75. Colorectal cancer screening is genuinely one of the great successes of preventive medicine. Colonoscopy doesn't just detect cancer, it can actually prevent it by removing precancerous polyps during the same procedure. For adults in their 50s and 60s who have never had a colonoscopy or who have a family history of colorectal cancer, it remains a powerful and well-justified tool. But the risk calculus changes meaningfully after 75. Here's why. First, colonoscopy itself is not a risk-free procedure. The bowel prep is physically demanding, involving significant fluid and electrolyte shifts that can be particularly taxing for older adults with heart disease or kidney disease. The sedation required carries risks that increase with age. And the procedure itself, while generally very safe, carries a small but real risk of perforation and bleeding, risks that increase in older patients and in cases where colonoscopy is being performed more frequently in someone who has already had multiple negative results. Second, even if a polyp or early-stage cancer is found in a 78-year-old, the benefit of treatment needs to be weighed against that patient's life expectancy and overall health. An early-stage colon cancer in an otherwise healthy 78-year-old is absolutely worth treating. But a small, slow-growing polyp found in an 82-year-old with heart failure and diabetes may never have caused that person any harm in their remaining lifetime, yet finding it may trigger a cascade of interventions. The USPSTF currently recommends that the decision to continue colorectal screening in adults aged 76 to 85 be an individual one, and that screening is generally not recommended after age 85. If you have had multiple prior colonoscopies with consistently clean results, your physician may reasonably suggest that the evidence for continuing is thin and that the risks of the procedure now outweigh the likely benefits. The fourth screening is routine mammography in women over 75. Breast cancer screening is an emotionally charged topic, and I want to approach this with the respect and nuance it deserves. Mammography has saved lives. That is not in question. For women in their 40s, 50s and 60s, especially those with risk factors, regular mammography is strongly supported by evidence. But for women over 75, the picture becomes genuinely uncertain. The reason comes down, once again, to overdiagnosis and the question of what happens after a finding. Older women, particularly those over 75, are significantly more likely than younger women to have mammograms that detect small, slow-growing cancers, or even benign abnormalities that would never have become clinically relevant in their lifetime. Yet once something is detected, the path almost always leads to biopsy, imaging, and often treatment. The anxiety created by a callback mammogram being told you have an abnormality and need to come back in is not trivial. Research has shown that women who receive a false positive result experience measurable anxiety and psychological distress for months, sometimes years afterward. And the treatments for breast cancer, surgery, radiation, hormone therapy have side effects and recovery burdens that become more significant as a woman ages and as her other health conditions accumulate. The USPSTF, as of its most recent guidelines, does not have sufficient evidence to recommend for or against routine mammography in women aged 75 and older. Major medical organisations differ somewhat in their guidance. What this means practically is that this decision should be highly individualised. A 76-year-old woman in excellent health with no other significant medical conditions may reasonably choose to continue. A woman of the same age dealing with advanced heart disease or other serious chronic illness may find that the benefits are outweighed by the burdens. The critical thing is that this should be an active, conscious choice, not a reflexive, automatic continuation of a habit. The fifth screening is full-body CT scanning, sometimes marketed as executive health or preventive whole-body imaging. These are not tests your primary care physician typically orders. They are often sold directly to consumers through specialty imaging centres, marketed as a way to catch hidden cancers, aneurysms, or other silent threats before they become problems. The pitch sounds compelling. Who wouldn't want a complete map of what's happening inside their body? But the medical evidence here is strikingly unfavourable, and multiple professional organisations have issued explicit guidance against routine whole-body CT scanning in asymptomatic individuals, including the American College of Radiology and the American Cancer Society. The problems are numerous and serious. First, radiation exposure. A single whole-body CT scan exposes you to a significant amount of ionizing radiation, roughly equivalent to several hundred chest X-rays. While the absolute cancer risk from a single scan is small, it is not zero, and in an older person who may be inclined to have repeat scans, the cumulative exposure adds up. Second, and perhaps more importantly, incidental findings. Virtually every whole-body CT scan in an older adult finds something: a small nodule on the lung, a slight irregularity in the kidney, a cyst on the adrenal gland. The overwhelming majority of these findings are benign and will never cause any problem. But once they are found, they cannot be unfound. They create what physicians call the incidentalomy, a cascade of follow-up imaging, specialist referrals, anxiety, and sometimes invasive procedures, all chasing findings that were never a threat. Studies have shown that the rate of significant, actionable findings on whole-body CT in asymptomatic people is very low, while the rate of false positives and unnecessary downstream procedures is very high. For older adults who are statistically more likely to have benign age-related changes that appear abnormal on imaging, this problem is amplified. If you or a family member is thinking about whole-body CT scanning as a proactive health measure, please have a serious conversation with a physician you trust before spending the money and accepting the risks. Now, it's important to step back and hold two ideas at once here. The first idea is everything we've discussed, that some screenings carry real risks for older adults and deserve more careful, individualized consideration than they often get. The second idea is that many other screenings remain genuinely important and life-saving for people over 60, including blood pressure monitoring, diabetes screening, cholesterol testing, skin cancer checks for those at high risk, and screenings for osteoporosis. The goal is never to avoid all medical testing. The goal is informed, personalized decision-making, what the medical world calls shared decision-making, where you and your physician sit down, look at your specific risk factors, your health status, your values, and your life expectancy, and make a thoughtful choice together, rather than running every test on a predetermined checklist. If your doctor recommends any of the 5 screenings we discussed today, don't simply refuse, ask questions. Ask what the potential benefit is for someone in your specific situation. Ask what happens if a result comes back positive, what are the next steps and what are the risks of those next steps. Ask whether the evidence supports this screening for someone your age and health status. A good physician will welcome these questions. They are the questions of an engaged, empowered patient. To bring everything together, after the age of 60, routine medical screenings need to be evaluated through a more nuanced lens than simply early detection is always good. The PSA test, cervical cancer screening after 65 for low-risk women, colonoscopy after 75, mammography after 75, and whole-body CT scanning all represent cases where the risks, including false positives, radiation, invasive follow-up procedures, and overdiagnosis, can genuinely outweigh the benefits depending on your individual circumstances. Knowing this doesn't make you less of a health-conscious person. It makes you a more informed one. The single most powerful thing you can do with this information is bring it to your next doctor's appointment and have an honest conversation about which screenings truly make sense for you right now at this stage of your life. If you found this information valuable and you believe it could help someone you love make better health decisions, please take a moment to share this video with them. Subscribe to this channel so you never miss evidence-based health content like this. Hit the like button if this opened your eyes to something you hadn't considered before, and drop a comment below telling me what health topic you want us to tackle next. Your health decisions deserve more than a checkbox. They deserve real information, and that's exactly what we're here to provide.